Well, Kerry, I have noon, so we will go
Okay.
ahead and get started. For those that have joined, the presentation and associated handouts were sent yesterday afternoon to everyone, so I hope you have those. We requested that you pull a wound care swing bed medical record and the associated detail bill so that as Kerry goes through items, you can see what is maybe missing in documentation, missing in the billing, because as we've worked with different hospitals across the state, we're finding there are a lot of things missing in billing. And some of it's due to documentation, some of it's due to just being missed in billing. Wound care is one of the more complex typically, and a lot of cost associated around that. So that's why we selected wound care. So Kerry is going to be going through today pertinent documentation, things that CMS is going to be expecting. Today's session is very informal. We made it a smaller group intentionally. Feel free to unmute and ask a question at any time. Kerry will be asking for feedback and input. So the whole point is, we just want to make sure that one, you know what CMS is expecting and what surveyors will be looking for, and two, you're achieving maximum reimbursement for your cases and really being able to build your swing bed area. So Kerry, I'll turn it over to you.
Thank you very much. And as Becky just said, we're going to go through a lot of things, and actually a lot of the first slides are going to be looking at how CMS watches this and how the auditors and surveyors looking at it. So hopefully it'll help you be ready for survey because they really still are surveying COVID or no COVID. The other piece of that is these slides have more information. They're not just bullet points that I usually use. They have more information. And I will go through a couple of pieces on each slide, but I built them out this way so you would have a teaching reference. You could go back because there are specific questions and statements that surveyors will or could ask you. And I want to make sure you have a chance to review that with your team, as you do your ongoing education. And as Becky said before, I kind of switch into the presentation, the real important thing for critical access hospitals, we don't think in terms of the money piece as well as the PPS do. And the PPS got trained starting in the late 1990s to pay attention to money because they went to a per diem system of a flat rate that's nationwide. It's not based on your facility's cost report like critical access is. So if they're particular, let's say it's a wound care patient, whatever that primary diagnosis, which would be the root cause of the wound is, that determines the amount of money they're getting. So let's say they're getting $500 a day. They can spend $1,000 a day in wound care supplies and they're still going to get $500. That's it. So what 10 years ago and 20 years ago now, people learned to ask doctors about, do we have to use the $1,000 tube of medicine, or can we not use this one that costs us $100? If we think it's good for the patient. This isn't in place of patient care. And they also learn not to admit some types of patients because they couldn't afford them, let alone sometimes it's competencies. Now, when we get into the critical access swing beds, everything goes on the claim. And ultimately, when your cost report time comes around, it gets settled out and your rate goes up or down. So what Becky's talking about is if you're providing that $1,000 tube of medicine for wound care, and it's getting on the claim because it's $1,000 and everybody's paying attention to it. We're not paying attention maybe to all the supplies going through the claim, maybe some of the other meds or powders that are being used going to the claim. A wound vac, the supply cost there is really abnormally high for the going rates. So if it doesn't get to the claim, you're not going to get reimbursed for it. And at the end of the year, if all those are getting to the claim, then your rate can go up. And so when Becky says they're finding a lot of wound care supplies, for instance, as one item that aren't making it to the claim, that may be $100, $150 a day take that times the number of wound care patients you have and the number of days they stayed, and it's a pretty sizable amount. And then just figure out if it's happening for wound care patients, chances are it's happening for somebody else. So the other warning I will put on you really is medical necessity. Just because you are getting reimbursed because you use that supply at cost, doesn't mean that Medicare is not going to come back and say you didn't have to use that $1,000 tube of medicine. You could have used the $200 version in our eyes, and they'll start taking back money. So the game for you guys is, one, to clinically make the right choices. Two, make sure the clinical documentation supports your choices, and that's all disciplines. And then three, test the flow from your chart to that detail claim. If you don't have one, you need to pull one for a chart and corresponding claim. Detail bill, and then the claim, and we start matching them up. And you're going to find gaps, I suspect, because Becky and some others have been finding them as they've been going around the state. And Becky and I were in an Indiana site last year, and we found tons of things that weren't getting captured. So, and by tons of things, I mean a lot of money. So that's sort of where we're going, but I'm going to start today. I have some learning objectives, but we're not formally doing this. As we said, this is informally, but I wanted to kind of keep myself in gear, and this is how I do it, so it's there. And then I have, as always, an update from CMS. This one's about the new MSP. If you've been on other calls, you know that it's the Medicare Secondary Payer Questionnaire. It's one of those 5 or 6 compliance pieces of paper that we must have, or we start getting money taken back. In theory, it's done in registration, admissions on the front end. It's probably computer-based in your facility. The reason I'm pointing it out to you guys is because I suspect most of you are clinical people, is some programs have nurses fill out the MSP if the admission's after hours. In other words, registration isn't available. So it's important as your facility gets ready for this new MSP, that if that's the standard in your hospital, that you make sure registration admission, whoever's over that, is training your staff, for the after hours implementation of this too. And the curious thing is, it is totally replacing the existing questionnaire. So the training's more important probably this time than just being told, oh, there's 5-word change to it here. The entire document that we have used, again, for about 20 years is gone, and they have replaced it with this. And I put up the MLM matters there, and I think that's in your handouts too. And it starts December 7th as a requirement. So make sure your team's ready for that, meaning your entire team and not just registration. It's a good time to remind administration, admissions, registration, all those type of guys, that just because they've been in your acute bed doesn't make that MSP valid for your swing bed. You must have a new MSP for every swing admission, whether they've come from your hospital or an outside referral source. COVID, as you know, and I'm not going to spend any time on COVID because, the 2 huge things that if you heard us talking earlier that I'm seeing across the country and you're seeing firsthand, is one, that it is really exploding on all of us again. And 2, we had a shortage of clinical staff well before COVID hit our shores, and it is just, it is something how that has complicated everything. The reason I put up this particular piece of information is because we're talking about wound care. Do you remember all the way back in March, we had a lot of decisions CMS was making about what was an essential service and what was not. And remember, we had to give up, in theory, elective surgeries were one of the things that got sidelined, which hurt everybody. Hurt doctors, it hurt patients, it hurt hospitals doing those services. The Alliance of Wound Care stakeholders, and it is a wide alliance, they really did well getting together quickly, and they commented to CMS saying that that wound care patients are fragile enough, and they are high risk often because of the comorbidities, that wound care should be considered essential, and it did hit the essential category. So that's the information there where actually lobbying worked, which sometimes is really kind of cool for all of us out in the field. So this is one of these sheets that I'm not going to spend a lot of time on because, first of all, if you remember, I'm not a nurse. If I was a nurse, I would never be a wound care nurse. I have my friends start discussing wounds around me and I get green around the gills. So not my area of expertise. So this language here comes directly from CMS, and that's what you're going to see for the next, I don't know, 5, 6 slides is CMS language. The more you can document, the more you can prove what CMS wants to pay for in your documentation, the safer you're going to be on any review or audit, and certainly any survey. So mostly we're going to talk about chronic wounds today. Obviously you have surgical wounds and some other things that may be new wounds, but in the chronic wounds, I think the important thing that I get from CMS is that underlying situation. So are they a diabetic? Are they obese? You know, anything that makes the skin fragile, including aging, that has caused immobility, I think is the other big area that CMS is getting ready to focus on. So this is the wording that came directly from CMS because they've started to look at the cost of controlling chronic wounds. And so you see this line here, implement wound prevention and treatment guidelines. You want to make sure you're reviewing your policies. You want to make sure you're reviewing your processes, and therefore your documentation on what you are doing to prevent wounds. So it is, you know, in hospital beds, it's capturing people as the skin areas get redder or shear is taking place, that we are not only getting aggressive in treating it before it goes any further, but that we're documenting that you caught those things, and certainly your treatment guidelines. All right, so the main causes, again, all of this, this particular thing is a mix of CMS language, and the statistics actually came from the National Pressure Ulcer Advisory Panel, which you now know is sort of our national standard for staging wounds. Skilled nursing used to have a separate staging schedule from the panel, and they actually joined in with them a couple of years ago, so now it's at least more universal. Obviously, aging is part of it. Obesity and diabetes, I just mentioned. The one interesting thing on this list to me, because I've seen it in a couple places now, is the increasing number of veterans in need of wound care services from injuries in the service, and then whatever's occurred to them when they got stateside, they're more prone to, some of them are wheelchair bound, some of them have lost limbs. I mean, there are thousands of reasons for it, but it must be a substantial list of them. The interesting thing for CMS to be talking about is, as you know, we have a veterans health system, and many of our younger veterans that need care would be getting it in a veterans hospital. To make this list means that we have a number of veterans that are hitting Medicare age, or more likely, we're hitting the disability requirement for Medicare, and so they now can fall under Medicare services. And there's, your financial people can tell you that they can go either way, but it looks like CMS is seeing increasing numbers of veterans qualifying for Medicare services. The other thing that Medicare is concerned about, and certainly is something that you all need to be doing, competency-based training, and obviously making sure that you're checking to catch them early enough with the medical device-related pressure ulcers. And I think the language for years in the industry, certainly in the nursing home industry, has been bed sore of the ear because of oxygen tubing. But we've got the tubing, we've got cervical collars, we have catheters. I mean, I can't name all the stuff that we potentially have bearing down on the skin. These numbers here surprised me, and this did come from the panel, which is 74% of the medical device related pressure ulcers were not identified until they were stage 3, 4, or unstageable. That's a really significant number, and I'm not sure what's behind those numbers. I do know that if a surveyor came into a nursing home and saw that, that facility would be cited pretty heavily. So please make sure that if you have any medical device related pressure ulcers, that you are tracking them and the staging of them. And it might be something that you want to take, you know, to your quality team as a review point to see if you are in a better range than that. because the next number is even more surprising to me, is that once that occurred, 63% of the cases had no documentation of skin inspection, device removal, Q shift, or whatever your policy has set up for that, or pressure relief. And I would think those are three like ABCs of wound care, particularly when there's an obvious wound. So pay attention to all this in here and make sure that your process for identifying it, your policies back that up, your competency-based training back it up, so that you have all of that in place. And as you know, a couple of years ago, they added the terminology for pressure injury prevention. These numbers are all over the place in the next couple of slides that come from different sources, which tells you we're not doing a very good job right now of universal tracking of this. Maybe another reason CMS is honing in a little bit on wound care. But annually, the estimate is that 2.5 million patients have pressure injuries. And then the routine prevention measures. In other words, I'm going to talk a lot today about transitioning patients, and it is part of the care transitions that we're all talking about, but I want to talk about in terms of wound care specific, meaning you get an acute patient who already has a wound. If that information isn't passed on to you in full, then we have a gap, and that patient can suffer because of that gap. And then we figure out what we have to do in the swing bed, because we actually have more time than the other settings. And then we pass them on to home health, or maybe to a wound clinic, maybe to a rural health clinic, depending on what they need. And what I'm suggesting in that transition of care, when we look at wounds specifically, are we really providing all the information to the next setting? And how do we coordinate? Because we are getting those patients back in the hospital. Where did it break down? Where the information, what that patient needed? Now, as you know, there's a good percentage of these patients that are on the far end, and we're not going to heal these wounds, and we're not going to keep them from developing new wounds. So it's a matter of trying to make sure that we control the ones that are there and prevent the ones that aren't there yet. And we can't do that in our little silos of healthcare. So I think there is some transitions that have to occur. So CMS said, you know, planning of care, I think was their terminology here. But there are some issues, none of which surprise me. But are we documenting those things? So nutrition, skin moisture, probably oxygenation, but I'm not sure the mobility issues. We would have to look at rehab and 24-hour nursing care to see if there's any reference that ties that mobility to trying to keep pressure off an area of the body or multiple areas of the body. So that's something for you to check. And then as far as the planning stage, again, I'm not going to go through this list. It is a list that you are aware of about weight loss and toileting plans and friction and shear and so forth, but it is straight from CMS language. So make sure that you have documentation and all that. And the last area here, it is important with dressings to know what is not covered by Medicare or other insurances. There's plenty of them out there. How are we making our choices on wound care supplies? I think that's a team discussion, your finance team and your clinical team together. This is not a finance decision over clinical, but there are plenty of choices within a range that are more affordable. And then it may be education of your either hospitalists or PCPs or others. But it is a team effort if we're going to get medical necessity, cost control onto our claim appropriately. Again, as I talk money today, please remember I'm a patient advocate. I do not want you taking away care from the patient, but we have choices and sometimes we don't stop to think about those choices. So a good time to review it if we're looking at wound care. This is the one that really is, yes, yep.
This is Becky, and I was just going to share, you were talking about mobility. We found some CMS education. They have some quick videos that is really MDS training, but it gives you a sense of the types of documentation they're looking for, good training information. The videos are very short. So with the recording of today's presentation, I will also send you a link that those are some real quick videos that provide some good information on particularly section G of the MDS.
Very good. Thank you, Becky. And Becky, while we broke in here, so I don't forget it, do you want to tell them about the wound care nurse and the Indiana rules on that?
Yes, the question has come up, if you need a wound certified nurse, if you take wound care patients. And so I connected with my contact at the state, Jennifer Hembry, and she indicated that no, they do not need to be certified, but what surveyors would look for when they came on site was their HR file to see if they have the appropriate experience and training for wounds. So Kerry's presentation today can be used as some of that education if you're needing to do that. But for those of you that don't have access to a wound clinic and certified wound nurses, it's not a requirement for them to be certified in order to take care of patients with those particular diagnoses. So,
which is really pretty good right now, considering we're in flux getting nurses, you know, in the buildings. So it's important. All right, so these stats are all over the place. So worldwide, one estimate is that we're looking at 60 million people with all the different types of ulcers. And these 2017, I don't know why, but these were the latest figures I could find getting ready for this. But chronic wounds affected 6.5 million Americans. This number came from the National Institute of Health. That's usually a pretty reliable source for statistics. In 2014, so 3 years even earlier than that, the wound care cost for Medicare beneficiaries and the ranges when I was looking up the information went from 28 billion to almost 97 billion. The last one coming from the article that I've cited below. So that I just try and split it and say 60 billion, but even if I went with 28 billion, do you hear that? It's not 28 million, it's 28 billion that Medicare is paying. So this is something where I think COVID has slowed up a lot of the surveys for swing beds in particular in most states for very obvious reasons. But when they get going again, the wound care is going to be an area they're going to be looking at. And as I suggested before in that transition of care, they're going to be looking across the spectrum. What did they pay for while they were in your swing bed program? And did they have to pay for the same things when they went to the wound care clinic or to home health? In other words, what's the progress being made? And if it's not being made, how well documented is it that this chronic wound is in a, you know, where we're just trying to control and maybe even pain manage at this point, but we need to have that documentation. It is one of the most common conditions in acute care, about 10%. Again, that was a 2014 number that actually came from the panel. And then all patients, pressure ulcers, they had in 2014, that was 11 billion just for pressure ulcers. And as you know, we have other types of wounds. So CMS and Joint Commission have put out plenty of documents that say that pressure ulcers are expensive, that they increase mortality and morbidity, and they play a role in spreading infections. And what's not there in red is they're saying, and we're spending a lot of money on it, what are we getting for our dollar? And more importantly, if we're spending all that money, we either need to label it as we are controlling it or we are seeing improvement. Either way would be fine, depending if that's an appropriate definition for each patient you're treating, but without explanation, we're going to be in some trouble going forward. All right, so this next slide is some just terminology that I found over the years, I have found in different sources. The one on the left are treatment options that we can have access to in skilled. Most skilled nursing facilities don't do a lot of them, again, because of cost. You know, they're not one of the excluded services. Like HBO is not an excluded service for skilled nursing, like dialysis is and some of the other ones for PPS settings. But those are kind of the national areas that we are looking at. And then the one on the right goes more to the wound clinic services available and things, choices. And the interesting thing about wound clinics, or actually rural health clinics would be the same one, is the choice of multiple specialties of physicians. So that combined with telehealth is giving us a lot more options, and we'll talk in a minute about wounds and telemedicine. But that's a list for you to consider and see what you're doing, if there are reasons why you're not doing. And as always, remember, I'm looking at CMS. You also need to look at Indiana regulations. So if you have questions about that, I'll refer you to Becky, because she does have the inside sources to check on things for you. All right, so as you know, in critical access swing beds, you do not have to do an MDS. Your counterparts in rural hospitals have to complete an MDS, and all 16,000 nursing homes in this country have to do an MDS. Why it's important, again, if you've heard me speak, I'm a firm believer that when CMS provides us the language and the level of care they expect for skilled care, and we're not using it as a training tool, we're getting ready to fall in a deep, dark pit. So by using the Swingbed MDS as a training tool, Becky talked about Section GG, which is the new functional gain language that we're moving toward. You know, that's a section your team needs to start changing the documentation into that language. Section M in the MDS is the where we have all the wounds. And associated with the MDS, and you will see it down at the bottom here, is reference to the REI manual, which is a Resident Assessment Instrument Manual. It's over 1,000 pages. I should have looked at it last night, but it's well over 1,000 pages now, so don't download it. Plus, they change it all the time. But have it as a link that you have starred so you can get to it. So if you have a question about, and you're working and training on how to document different things under specific types of wounds, this is where I believe you need to go, along with some other national standards that you're quite well aware of, and use this to train your staff. Now, in May of this year, they actually did two things. One surprised me, the other one didn't. The one that didn't surprise me was they broadened the scope because of the pressure injuries. And not just pressure ulcers. We expected some of that. And then the thing that did surprise me is they removed some things from Section N that they had to report, but they didn't remove them, the fact that we have to document them. We must document them, but now we don't have to report them on the MDS. That's almost setting you up for a survey issue, honestly. So one of the things that they have emphasized, and I have it there in red, is they really want you to be clear whether there's a pressure ulcer present on admission. And if we're not doing a good assessment at admission, we're in trouble. Because if something develops while they're there and we go back to the initial assessments and there's no mention of any kind of skin area that looks questionable, you're going to get stuck with a potential fine on a survey. Now, again, the key elements that we used to have to report about the wounds, you must still document. So your wound care documentation must still include the staging of the wound and all those things that we have been doing on an ongoing basis. So the items to include in that next bullet point or arrow point are the ones that are straight from the CMS rules. That's their language. So I have provided that hopefully for you to use as a reminder. I think this is that list is pretty basic. And when we look at the next slide, this is actually the first page out of Section M on the MDS. If you haven't looked at an MDS, this is what it looks like. It's full of words and boxes. But what's actually pretty helpful about it, it will say to you, pressure ulcer, and then it's very specific. There's a non-removable dressing or device. I mean, so it gives you hints. There's an assessment tool. It even tells you which assessment tools they prefer. You can come down here and they'll define skin intact or not and what's going on. So the language, again, when you go to document, they're providing you language that you could use in your documentation, particularly here where I'm looking at stage 2 and stage 3, and we're looking at slough really is the only difference there. That's important that we get that documented between those. The other interesting thing is in this MDS version, they put up here in large letters about don't reverse stage. If you've been around wound care for a long time, you know that we didn't reverse, then we did reverse for a long time in skilled nursing, and now we're back to not reversing. But the fact that CMS has that in all caps, and you see the size of the rest of the printing, I'm not sure why they're worried about that, but please make sure your program is not doing reverse staging. And this is one of 3 pages just on skin conditions. And this version right here, if you go out to CMS and look for just the MDS, when you open, there's a file, and when you open it, I think it's the second to last or last item choice. But what you're interested in is that SP as the first, that's the version for swing beds. And the current version, they did not go to 0.2 on October 1 because of COVID. They backed off lots of changes that were supposed to hit us in the industry on October 1. They went to 1, or now may be 0.2. The key thing is you need to have the version 17 at least until COVID is cleared out, and then they have to go through a whole process to move everything to the 18 version. All right,
Kerry,
so here's what, yes.
we do have a question.
Okay. I lost you, Becky.
I accidentally muted myself, I'm sorry. Any requirements for pictures of the wound to be provided or documented?
Not on a national level anymore. There may be on a state level. I don't know of one at a state level. The important thing will be to follow your policy. That will be where they start. And Becky, maybe we need to check with the state and see if they have anything on it. I don't know many states that have intervened on that. As you know, there's been pros and cons about photos, the value of them. And I'm going to take this out another step here in a second. The value of them, because you can show a reddened area at admission, for instance, and then show the same area with the wound, you know, a week later or whatever. It's not that you didn't capture it. It was, you know, unstageable or whatever was going on initially. But the other thing was then lawyers started using all those photos against nursing homes. And so we're in that fine balance there. So I think your policy is the main thing. But here's the second interesting thing. We're going to talk about, I think it's on maybe even the next slide. No, it's a couple slides back still. We're going to talk about telehealth for wound care. And they're calling it telewound. And it is a way to have a wound care clinic with the certified wound care nurse or with a physician who specializes in wounds available while you have somebody in a swing bed, because you remember you typically have them 2 weeks or so at least, sometimes longer with wounds. That gives you a way to have the intervention of a specialist and not having them sent out to a wound care clinic. That obviously has been birthed during COVID, just like all the telemedicine. I saw a report this morning that kind of made me crack up, because this is the first time I've ever seen this kind of thing happen where CMS wasn't upset. The difference between November of 2019 and November of 2020 in telemedicine, it's up 800%. Usually CMS would have been screaming by now for paying for that much of it, but that's that COVID bubble that we're in. So the telewound is coming out as if you have a good wound care clinic in your own system, or perhaps in a larger city where you can use a specialist. I've got some swing bed programs in multiple states that are taking sicker specialty patients that are calling into the major hospital system, and they treat those kinds of patients, and they're using specialists via telehealth. So, you know, I would say use it wisely if you're taking pictures, and make sure it follows your policy, if that helps. All right, so all of this is laying the groundwork of how we've got to document it, pay attention to it, have a team approach to it. And when we're talking about mobility, and we're talking about skin, and we're talking about nutrition, that's not just a nurse, it's not just a therapist, it's not just a dietitian. It literally goes to our IDT. And the source that I will bet my bottom dollar that state surveyors or CMS surveyors will look for when they come in will be your IDT documentation. So please make sure it makes it not just in the daily chart stuff, but also into your IDT. Here's the problem. If any of it's not being done well, there are what we call FTags. Nursing homes are very used to them. If you've been around skilled nursing, you've probably heard the language. F stands for federal. And in this case, they've actually got 2 tags, 686 and 687, that are for skin in particular, or wounds in particular. This is a slide that I'm not going to read all the items. This is the exact language from that FTag violation. And if you don't meet those rules that are there, then you can be issued a citation, and a citation about 95% of the time now comes with a fine. There are a few circumstances where they'll let you correct something while they're on site, or they will decide to give you a warning when they go back. They go back to their state offices and decide final, reports to be sent to nursing homes and swing beds. But it's a very small percentage. I think the key thing for you to take from me today is that it's not just writing in the documentation what you are doing. And in this case, this is the paragraph on avoidable and unavoidable wounds. It is, did you adjust the care plan? So if they see a note in your documentation where something of some significance occurred, that survey team is going to go to your care plan and see if it's been adjusted on the care plan, that you don't just say on the care plan, have the wound and we're going to do this medicine, that it is a living document that says, here's where we are with this patient. In the old days, not that long ago, but in the old days, survey teams, if they came in and they saw a care plan in a nursing home with nothing scratched out, nothing initialed, they went after them because they figured they were not updating the care plan. And those, when we were on paper, they expected to see changes on that paper document. I had so many people that got fined because all they were doing was, before a survey team came in, they were cleaning up the document so they could read it better, and they took away all that documentation they had done by hand, and they got stung for it. So the equivalent of that hand writing being on the documentation, they're going to look at your care plan and make sure your care plan's adjusted. So baseline care plan that you do within 48 hours of admission, comprehensive care plan that you do if they stay long enough, that document is to be used in your IDT meeting, and changes made that show that it was an IDT a group that was working on that plan. So I think that's the important piece that's a little different from other things that you have been looking for. The other thing is, I have put on here, this is again specific, and you can find this, the State Operations Manual. Appendix W is specific to critical access hospitals, and there is a section in there on critical access hospital swing beds, but it's Appendix PP in the State Operations Manual that's for surveyors. The good thing about it is everything is listed on what questions or what documents they should seek to be able to fine you or have a disciplinary action against you. You have a heads up if you will go look at that section. By the way, it's all in red right now online because I've made so many changes, but this is the language. So they will issue a citation for these 3 things right here. And you can read them. I mean, it's nothing that would surprise you, but they're laying out very specific. And this unavoidable, they want to make sure that it didn't increase. And then obviously the rest are avoidable, ones that they would be citing or paying more attention to. So how do they know that you've done something about these 3 items? These guidelines define documentation requirements, and there's the list. So it's right in front of us. It helps to train to this. This is, again, part of the competency-based training you can do. And I'm going to say right here, everything we're talking about today, we don't expect you to have meetings on it this week or next week. Obviously, if you're taking wound care patients, you might want to talk to some of your staff about paying attention to this. We understand by doing this at this point, COVID takes the highest priority at this point. But if you glance at this list here and go, I'm not sure we're doing that very well, maybe that's something 1 or 2 of you can look at in your own programs and see if something needs to be adjusted while we're kind of surviving this stage of healthcare. Here's my reference to the telewound, so I won't go back through this, but I want you to start thinking in terms of some best practices. It would help, and be grateful for any best practice ideas you have. I'd love to share them with other people. Becky likes to share them with others, so just let us know. I'll go back to IDT being really, really important in this, including the physicians involved in these decisions. A physician, I will say, because there could be a hospitalist or PCP or whoever else you have. Whatever your policies and procedures are on pressure ulcer prevention, that language can really help you, and then the training you do from that language in your policy and process would be helpful. Any standardization with evidence-based practices, we have a lot of changes all the time. You see here EMR supporting HIPAA compliant photo documentation, so it's not that it's gone away, and that's where it's going to be used for telewound. A big area right now, obviously, is pain management. If you've been around wound care patients, you know that it can be severe, and we have depended heavily until the last 18 months on opioid choices. That may still be the choice that we have to make to put somebody or continue somebody on opioids. That's going to require a lot of documentation considering the focus on that. Care coordination, you know, what's best for this patient. And what's interesting in the CMS language to me is care coordination focused on reducing unnecessary costs. So that goes back to the fact that any supply you use, you can put on your claim legally and legitimately. The question is, before it got to the claim status, did we make the right choice clinically for that supply, and do we understand the costs enough if there were several choices that we did the most cost efficient choice? And remembering these guys are going home to co-pays on their medicines and that sort of thing, and they may have that huge cost out of their pocket too. And a very big item everybody's looking at now is not just patient, but patient and family self-management tools. So if you haven't developed something like that or don't have something access like that, I would, after we get through the COVID stage, I would make that sort of a star point for you to look at, because we want to do that care coordination. We're sending people out to other settings or sending them home, and we really want to make sure that they have the materials and sort of basic understanding of it anyway. Algorithms that you can use. Yes.
I was just going to say, everyone was provided with the state operations manual on this particular topic. Yep. And I did just flip open back to the photographs, because my contact at the state often refers me back to the state operations manual if Indiana doesn't have anything separate. And within the state operations manual, it says, photographs may be used to support documentation if the facility has developed a protocol consistent with professional standards and issues related to resident privacy and dignity are considered and maintained. So that's within that handout, but I will follow up with Jennifer too. But I came across that, and before we move forward any further, I just wanted to share that.
Perfect, perfect. I've included this as a training tool. I've actually had facilities that have used it with families to explain different things. So it's just there as a resource if you need it. The main thing about process issues is to make sure you standardize as much as you can and educate all staff. I know we have nurses doing wound care. We have CNAs in nursing homes going in and out of rooms, helping people toilet and so forth. And it's important that everybody understands, you know, the damage that can be done from moisture and other things. So you can read all of that. The interesting thing here may be the technology that we're now getting, nice programs to give us some algorithms, to give us alerts and so forth. I don't know, I haven't really seen anybody use this yet, but they're beginning to talk about it. What I would like to do is talk about QAPI, which is QAPI in CMS language, which is Quality Assurance Performance Improvement. This is a skilled nursing directive. They must do QAPI, but it's a good resource, and we've provided a QAPI outline of the materials that are out online by name to fit different sections, so you can look at that in your handouts. But here are questions that came from QAPI that are, again, very specific for wound care. And this QAPI was developed by CMS, so these are CMS questions. So I listed them here. So they want to know if you have a performance improvement plan. And then here we come again with patient transition and care processes, about the third warning we've had from CMS, that they want to know how we're helping the patient go through, not just what we did in our 10 or 11 or 15 days, but where did they go from there, and did the next setting do the next piece of it? On the next sheet, I have all the items that CMS expects for pressure ulcer prevention and treatment. This is under, again, the QAPI or QAPI rules, and you see there are 4 primary areas, obviously risk factors, pressure points, nutrition, hydration, and moisture and impact. I have 2 that CMS has quoted regulations. These are the federal regulations. That's what the FR part of that is. Most all the skilled rules are between 483 and 485 if you look up all the zillion of regulations in the world. You see the FTag tied to this. Remember, we were just talking about this happens to be for nutrition instead of wound specific, but there's the FTag for nutrition, and here's the regulation basis for the hydration, and there's the second FTag, and there's the language. You can see here, it comes down here, and here's the FTag here for urinary incontinence. So it's all tied together, and ultimately, if you do not refer to all these and train on all these and document well, you will end up with some citations under these surveys. This is another best practice. I had a team that did this because they were trying to figure out all the people that actually worked on, had something where the documentation or the information provided might make a difference. And their list is, I just think it's an interesting list of people because they went all the way down to clerical staff. In other words, getting orders timely, you know, and charts, all sorts of things that they were looking at that point. And information systems are really important since so much of what we're doing is now computerized. So that's another option. And I'm not going to spend too much on coding and billing, but I do want to say a couple specific things. And the reason I'm not spending as much time on it is the wound care and debridement codes. You have to put them on the claim, but you're not getting paid to those rates like the PPS settings are. You're getting paid under a hospital bundling rule. You're getting a per diem that is based off your cost report, not a national average. So that they're there so that the codes are correct. And you will see in your handouts, I've enclosed the 2020 wound care codes that are approved by CMS for this year. So you might want to double check with your billing, or if you have a wound care clinic, they should have the same list. The 2 things I really kind of want to go over right now. One is I checked with a lot of coding people, and they said there's nothing unusual or getting studied right now by CMS. In other words, they're not honing in on one thing. It's sort of business as usual. However, several of them mentioned that if a 7th character was required, it would be an A as an active, and that's because you are, one of the reasons they're in your swing bed is they're under your care. It might still be infected. You might be giving antibiotics, other services. So that was helpful. And then remember, in the bottom part of this slide shows that all services provided will be on your claim. So anything that has, you know, the wound care services, obviously any supplies you're using must be on your claim, and that goes back to what Becky was talking about as we started. For review considerations, the only thing that I found that started 2 years ago in HBO therapy in Wisconsin, and CMS has signaled again that they were headed towards reviewing HBO therapy. Obviously that's stalled now because of COVID, but here are the 4 areas they were reviewing. And the big one is using it for non-covered diagnoses. This goes back to the importance of coding the primary reason. The root cause of the wound is your primary diagnosis. It isn't the fact they had a wound. It goes to the way CMS is really looking at all documentation down. But there are 4 standards there that you might want to review with your team as a warning at how CMS looks at things. And the other thing that I am providing, and we're going to break out and see what information you have brought or if you have questions. But this is in your handouts also. This is the latest MLN fact on compliance for surgical dressing. So all this information CMS provides us. It's just we can't read a zillion pages and do our care all the time, so we're all kind of stuck on the hamster wheel right now, keeping up. So my last piece of this is I hope what you've heard is from the time somebody walks in the door, the clinical pieces of the pie certainly not only drive clinical care, they drive what's going to end up ultimately on the payment side. And having things documented makes or breaks us when clinically, and it makes or breaks us financially. So if you have pulled, and if not, I'm going to ask you in your spare time at some point to take a wound care patient chart, to pull the itemized bill. You're going to be surprised. I think we had somebody on yesterday that was pretty shocked about how many items were on that detailed bill, because clinical people don't typically look at it, and take the claim. At some point, whether it's with your IDT team, which I would suggest it would be, but some portion of clinical people, coding people, and billing people need to sit at a table and take those three source documents, meaning the chart, the itemized bill, and the claim, and match them up and make sure you're capturing everything and everything makes sense. So with that, Becky, do we have any questions? Or if you want to open up the mics, guys, you're welcome to ask me things or talk about things or make suggestions.
Absolutely. I mean, feel free to unmute your line and ask questions directly or chat them in. I would say that the most common areas we found missing when we sat down and looked at records were medications, and medications for wound care can be very expensive, but those were missed from the bill. Therapies were often missing, or maybe the frequency of when therapies were occurring were missed. What was the third one? Medications, therapy, I should have written them down. Oh, and the supplies. Supplies were often missed on the bill. So you definitely want to get those included because that can add up. And also that came up in discussion, the medications that patients are discharged on, making sure that they can afford the medications and the supplies before they go home so that you can follow through with that. One statement that just came in is, can you repeat the 3 areas that need to meet for the billing review?
Yes, I'd be glad to. So the first, and I'm going to say IDT team, because that's all your, if we're talking about wound care in particular, that's all of your components. The physician would be there, your nursing would be there, dietary nutrition should be there, and so forth. So it is, I'll say IDT team, you can take a portion of that. So that's clinical. The next thing is you want the itemized bill. It can be under different names, but your billing people will know what that means. It's a multi-page document that literally every time you scan a medicine, it should show up on that list. And one of the breakdowns that happens is that as we're scanning and or writing, or doing however we're accounting for supplies and meds, for instance, if it's not in what we call a charge master the right way, it doesn't get to that itemized bill. There's a breakdown, and that's why this review is so important. If it doesn't get to that itemized bill, it doesn't go on the claim, because the itemized bill can be 12 to 20 pages long. It is taken down into the primary billing codes, they're called revenue codes, on the claim. And if you get the claim, you will see it's very, very organized. It starts with your bed rate, it goes into the 250 codes, which is pharmacy, and then it goes to 300 codes that has mismatch under it, 400 codes are therapy. I mean, it is very, very specific. And we can't get from what you're writing in documentation and what you guys, how you're scanning supplies and meds and other services in, if they don't get to that detail bill, we're not getting paid right. And that's actually underbilling and overbilling is fraudulent billing. Believe it or not, of course, CMS doesn't really ever go after underbilling, but that's in the language. So if you take a chart, electronically, go into a conference room, put it on the wall, start talking about what that patient got, start looking at what services, go to a daily nursing note, see what was provided, go to the meds, go to therapy, see what was provided. And then it should show up on the itemized bill for that day. And the other thing you see on an itemized bill and it happens, I think CMS thinks more than it should, but it does happen where we'll have a med put on that day and then we take it off and then we put the med back on, or we may have had 3 doses put on, but we only wanted 2, so 1 gets taken off. If that doesn't show up on the itemized claim correctly, then it goes to the bill, the ultimate claim that goes to CMS indirectly. So those are the three pieces of the pie. Does that help?
What other questions do you have? And now is a great time to look through that bill. And if you remember the patient that you pulled the record for, what kinds of things potentially could be missing. You definitely want to build a good relationship with your billing staff, include them as much as possible, and also make sure that there's a good relationship with your MAC who reimburses the hospital. They're typically pretty good to respond to any questions that you have regarding any billing kind of issues, or if you question medications that are covered, etc. What kinds of things are you finding missing, or what questions do you have? And we'll give you just a few minutes to look through your bill and your medical record.
See, I didn't lose power, Becky. That's a good day.
Yeah, I'm glad. For those that joined late, Kerry's in the middle of a hurricane there in Florida. It's been quite entertaining for her, to say the least. We really thought we might lose her today.
Yeah, let's say I have tree branches brushing up against my roof line. I can hear them. All right, so here's kind of my summary note is remember that I built this out as a training tool for you to go back and look at specific slides. So, you know, if with our staffing the way it is, with COVID the way it is, what I would suggest to you is if there's one item that stood out during all this going, I'm not sure we're doing that, or I don't know that we're documenting that, maybe you take that one item and go look at it and just figure out who on that team needs to help you with that item and keep it controlled until we get back to whatever our new normal will be here, hopefully sooner than later. But keep this as a starting point. There are plenty of references on the resources. We've listed all the main ones at the top, and then we've provided some materials down on that second list. And these are the starting points. If you use those first 3, plus a copy of the MDS, which is actually in the REI manual, you're going to be as ready as you can be for a survey team, whether it's state or federal. And then, as Becky just talked about, the MACs are the auditors. Your business department knows them very well. And that's your business, discharge people and financial people. So that's a good one when you get in the room with one time with both clinical and financial staff talking about it, and you start matching up these pieces. So hopefully this will help you have a tool that you can use ongoing when you have the time to set it up for your team.
We just have about a minute left. So if, as you're going through your medical record, you're going through your itemized bill and you have questions, reach out. We'd be glad to help you kind of resolve and clarify any of the information. The presentation and all of the materials were sent yesterday. That state operations manual portion was attached for reference, as well as provider compliance tips for surgical dressing, all of the codes that are associated. And I also included the quality assurance performance improvement, or that QAPI resource tools that Kerry referenced during her presentation. So I hope today's been helpful. Wound care is a big topic and lots to cover in a short period of time, but hope the information today was helpful. And again, reach out if you have any questions. And thank you so much, Kerry. And thanks to Ali Orwig with the Indiana Rural Health Association for supporting the Zoom for us today as well. Stay safe and take care. Thank you.